Good afternoon, everyone. A very warm welcome to today's session on diagnosing gastrointestinal pathologies through radiography in pets. We are honored to have with us our distinguished speaker, Dr. Arun Anand, whose insights continue to guide and inspire the veterinary fraternity. I am Dr. Vishal Sharma, a proud veterinarian and managing director of Oriheal Lifesciences. As a practicing vet myself, managing 2 pet hospitals in North Delhi under the name of Pets Planet India Pets Hospitals Private Limited, I truly understand the ground level challenges, hopes, and responsibilities we all carry. Buy a vet for the vet, a mission close to my heart. It gives me immense pride to share that Oriheal Lifesciences has grown into one of the leading manufacturers of veterinary pharmaceuticals with a product profile of 180 plus products. But beyond numbers, what truly defines us is our purpose. We are a company built by a vet exclusively to serve vets. Everything we do, be it innovation, education, or support, it's centered around empowering our veterinary community. We are here with safe, trusted, and first in India veterinary solutions. Our product portfolio continues herbal medicines, India's first 100% safe, sugar-free, and side effect-free formulations, safe even for a newborn pup and kitten. You can prescribe these medicines without fearing any side effects. Nutraceuticals, pharmaceuticals, injections, and grooming solutions, or carefully formulated for better compliance, a robust range of neuro, cardiac, ophthalmic, dermatology products tailored for small animal needs. Are strengthening veterinary knowledge across India. Under the initiative Buy a Vet for the Vets, we have created one of the largest platforms for continuous veterinary education through regular webinars. We aim to spotlight advanced yet often unexplored topics like feline medicine, cardiology, neurology, radiology, ophthalmology, and many more, because knowledge remains our most powerful tool in saving lives. Your support is our lifeline. Friends, this journey is only possible because of your unwavering support. Every step we take forward, every educational effort, every new product is fueled by your belief in us. We humbly request you to support this mission in whichever way you can. Even a small order, a word of encouragement, or referring us to a fellow vet. Each gesture keeps this mission alive. Ordering is quick and effortless. Just call or text us on the number mentioned in the chat box. Our team will personally connect with you to take your first order. We deliver directly to your clinic, no middleman involved. All benefits and support go directly to you, and we promise highest trade margins to our fellow veterinarians. Let's walk this path together to grow, to learn, and to raise the standards of veterinary care across the nation. Thank you for being with us and for being part of this journey. Warm regards. So we welcome Dr. Arun Anand on this platform. This is a third session is being taken by him. Dr. Arun Kumar.
Am I audible,
I request our admin to focus on Dr. Arun Anand, sir.
Yeah, am I audible, sir?
Dr. Arun Anand completed his graduation and post-graduation from Punjab Agricultural University, Ludhiana. He acquired doctoral degree from Guru Angad Dev Veterinary and Animal Sciences University, Gadwasu, Ludhiana. He joined as assistant professor in the Department of Surgery and Radiology, Punjab Agricultural University, and rose to the position of professor and head Department of Veterinary Surgery in Gadwasu. He acquired certificate of qualification from Canadian Veterinary Medical Association. He also cleared Education Commission for Foreign Veterinary Graduates, ECFVG program, USA, and registered as DVM with Michigan State Board of Veterinary Medicine, USA. His main field of work are in urogenital surgery, joint surgery, oral surgery, especially small animal endodontics, emergency surgical procedures, soft tissue surgery, and small animal radiography. Let's welcome Dr. Arun Anand. Thank you very much, sir, for being here. Yes, sir, you are audible.
Yeah, I thank Dr. Vishal for giving me opportunity to interact with the fellow veterinarians all over India, maybe some abroad as well, to discuss very important topic. So thank you, Dr. Vishal. So I'm going to start my presentation. As you know that there are a number of problems they come to us on daily routine practice that in which there is a need for radiography, especially for the digestive tract pathologies. So there are some points, practical points, which I'll be discussing in next 1.5 to 2 hours for like what we can, how we can look into the X-rays, which in a pet, in a dog or a cat, which is having a GIT pathology. So anatomically, if you you must be knowing that the whole of the digestive tract is a hollow organ, starting from the esophagus and ending up to the large intestine, so up to the rectum. It's all hollow organs, and it is involved physiologically. It is involved in absorption of the nutrients as well as the passage of the food. So that's why it's a very important organ. So whatever the nutrients the pets will be getting, so that will be absorbed through GIT. So another practical point is that it is highly dynamic system. So there will be lot of motions, movements going on, every movement inside the GIT. So there is peristaltic movement is there. So that is required to push the food towards from esophagus to the stomach and then to the small intestine and ultimately to the large intestine. So each and every part of digestive tract has its importance. So in terms of absorption, so another thing which is characteristics of this system is that it is highly mobile, means most of the part of the intestine or digestive tract that is mobile in nature. So that's why sometimes there are some pathologies happen because of this mobility, over mobility, like intussusception happens, or sometimes there is GDVs there because of the mobility. So one part of the organ that moves to the abnormal location. As well as there is some even herniation. Whenever there is a herniation is there, defect in the body wall. So these this digestive tract can go through the hernial ring into the hernial sac, and it can strangulate and can develop the pathologies as well. So in addition to these pathologies, so basically there are other problems are there which are mostly chronic in nature. Like there is obstructive diseases are there, or restrictive diseases which will. So my webinar will be around these three categories. The first category will be that I'll be discussing about the emergency and acute diseases due to displacement of GIT at an abnormal position, like gastrodilatation with volvulus and diaphragmatic hernia. So as I told you in the beginning that being a mobile, this part of this system is mobile. So that's why it's likely to go to the abnormal position, and that can lead to an emergency condition. So I'll be discussing part of first this one. Second, my webinar will be discussing about the obstructive diseases. So obstructive diseases because of some chronic conditions like neoplasia, or some acute condition like foreign body ingestion, ileus, strangulation, intussusception. So I'll be discussing about these things as well in my webinar. Then there is another category, third category will be the restrictive diseases. So restrictive diseases are mostly, they are chronic in nature, and slowly it will be developing. The history will be that it has a chronic vomiting, or there is a loss in body weight, and exercise intolerance is there, height bound condition, that there is the animal has lost a lot of weight and ribs are palpable. Then these conditions which doesn't allow the proper absorption of the food, these are chronic. So restrictive diseases are there. So it includes the hypertrophic gastropathy, pyloric stenosis, eosinophilic gastropathy, extraluminal space occupying lesions which affect the GIT. So my webinar will be on these three categories most of the time. So let's start. Aim of my presentation is that esophageal diseases and its radiographic diagnosis. Then it will be the gastric radiography as a diagnostic tool in emergency and other anomalies. Then radiographic insight of intestinal diseases. So in next couple of hours, I'll be discussing about these things, a practical point, and I'll be telling about those radiographs which we have taken at our institution, and I'll be discussing how to diagnose various conditions which are clinically very important. So first of all, what is the value of radiography in digestive tract? So it's having a huge, although like it's one of the oldest diagnostic modality, but still it's a very valid and it's a highly diagnosed. If you use it in a proper manner, then we can diagnose a number of diseases. Although like latest diagnostic modalities like ultrasonography or like even higher CT scan is available nowadays, but still this is a preliminary diagnostic aid, especially even in the remote areas where we can take the help of even human radiological unit to take the x-rays and to come to the diagnosis as well. And another thing is like radiography of the digestive tract. This can be the preliminary scanning diagnostic modality as well before undergoing any ultrasonography or any higher diagnostic or latest diagnostic technique. So it is very useful for screening the GIT of foreign body. So another thing is like the foreign bodies which are radio opaque in nature, which appear as a white in radiograph, so that the radiograph doesn't have any alternative, then this is very good diagnostic or screening diagnostic aid. And in addition to, there are some diseases are there in which there is ileus is there, means obstruction of intestine is there, and there is a lot of gas accumulation because of obstruction. And when gas accumulation is there, so then ultrasound might not work so efficiently. So in that condition, radiography will give you better idea as compared to the ultrasonography. So technique for choice in GDV as well. So if you look into the comparison between the ultrasonography in GDV and radiography, I will always keep radiography as a better technique of choice than ultrasonography. Then it gives a screening assessment of the abdominal content as well, and landmark prior to ultrasonography. It means ultrasonography and radiography, they will complement each other, and they go hand by hand in hand. Means you can't skip both of them. In most of the condition, radiography has to be done as a screening assessment before going to the ultrasonography. So then this can be a technique of choice for abdominal gas secondary to the rupture of the GIT. If there is a rupture of GIT, especially recently we came across a cat which was having a linear foreign body. A thread has eaten. The thread was from the mouth. It was hanging out of the anus as well. So whole of the intestine was having this linear foreign body, and there was a rupture. There was a perforation of the intestine, and that led to the abdominal gas accumulation within outside the intestine. So there, when the gas accumulation is there, then this is radiography is the technique of choice, especially when there is a rupture of GIT is there. So useful for demonstrating GIT involvement in hernias. So I'll be discussing few x-rays as well in which herniation, so diagnosis, especially when there is inguinal hernia or ventral hernia or diaphragmatic hernia. So then radiography is very good diagnostic technique to judge that whether the urinary bladder has gone into that herniation part, especially the perineal hernia, or the rectum has gone. So that's why the radiography has no alternative for GIT involvement, to judge the GIT or other organ involvement in hernias. So GIT contrast studies may be required for additional information on location and wall thickness of GIT as well. Although like the survey radiography means without contrast. So I'll be using a number of terms like survey radiography or contrast radiography. So when I use a survey radiography, it means it's a plain radiography I'm talking about. So although like the survey radiograph will tell you about the serosal detail, it will not tell you very good information about the mucosal detail inside the detail. But GIT contrast studies, we can, for mucosal detail, we can go for the GIT contrast studies as well. So this is the value of a GIT. So while taking the X-ray, one thing you must keep in mind that proper view and proper view should be there, and proper collimation should be done, so that so all the whole of the abdomen should be visible in single view. So if you look into the X-ray, you can see that if you want to look into the X-ray for GIT, especially for the stomach and the intestine and the large intestine as well, then the collimation should be done in such a way that diaphragm should be visible, and even the inner part, up to the inner part, or even up to the rectum and inner part should also be visible in that view. And for that, the collimation has to be done at the level of L2. At the level of L2, lumbar second, the collimation has to be done. And let me do it the marker as well simultaneously. So collimation has to be done at this level. You can see this is L2. So collimation has to be, and I preferably teach to the students that collimation, this is the last rib. So collimation can be done just caudal to the last rib. Not collimation, sorry, it's a centering of X-rays, because I told you in the previous webinar as well that wherever you do the centering, the good quality of X-rays will fall on that part. So that's why the centering has to be done just caudal to the last rib, and up to L2 as well. Then for VD view, you can see in the VD view, position are visible, that's fine. Then centering has to be done. Here, if you concentrate at this portion, the centering has to be done near, just cranial to the umbilicus. So this is how, so even you can see in VD view, the diaphragm should be visible, and even up to the pelvic bones. So this should be visible if you want to go for a proper diagnosis as well. So radiographic, there, whenever you read a radiograph, especially in terms of, I'll be concentrating most of the time like on GIT. So there are 5 distinct radiographic opacities of the biological material that will be visible when you look into that. It will be, that opacity will be from radiolucent, means black, to radiopaque, means white. Radiopaque will appear as a white, radiolucent will appear as a black. So there will be, so 5 densities can be visible. It can be the gas, it can be the fat, fluid, bone, and metal. So these are the 5 densities. They can be visible in X-rays. So gas will be mostly black in color, radiolucent in color, fat and fluid will be slightly grayish in between the black and white. Bone and the metal, it will be mostly white in. So that's why the foreign body ingestion, when there is a history of foreign body ingestion, especially if there is a metallic foreign body or some stone is there which are radiopaque in nature, then those white density can easily be visible in X-rays. So organs can be distinguished because of the abdominal fat. This is very important. So serosal detail is not so clear in puppies and kittens, because they have very minimal abdominal fat. More the abdominal fat, more contrast will be there. Serosal detail will be better in fatty animals, or it may be medial sized animals, or like healthy animals. They will have a better serosal detail as compared to emaciated or cachectic or pediatric patients. So intraluminal gas that allow the identification of, this is also like whenever you look into any, especially the small intestine, when you look for these loops, then follow the gas pattern as well. So I'll be discussing that when I'll show you the X-rays. So abnormal opacities, they help in diagnosis of the disease. So if there is abnormal opacities are there, so if there is a lot of fluid accumulation, lot of gas is there, or there is some displacement of the organ, and that organ has a abnormal opacity and placed at an abnormal position, so that can help us to diagnose a particular disease as well. So if you look into the X-ray, this is an X-ray of the cat. If you look into this one, so below the liver, this is the liver. So below the liver, if you see, there is a fat pad is there. This is called falciform fat pad. And this will, you can see there is a clear demarcation between the soft tissue of the liver and the fat. So that's why the fat is very good contrast medium. And if you look into the, because I told you about that GIT is a dynamic in nature. There is all contraction of the GIT always happens. There is a peristaltic movement happens every minute inside the body. So that's why the diameter of the intestines, they will also vary. So they will also vary. If you see, if you look into this one, this is the fat, and if you look into this is the intestinal loop. I am highlighting this intestinal loop. If you see the diameter of this intestinal loop and this intestinal loop, so it varies. It means that contraction in this second loop is there and the first loop is dilated. So this is a normal character. Don't take it as a abnormality that one loop is thinner, and this is all because of the peristalsis going on inside the body simultaneously. And even if you look into this, if you look into these white arrows, you can see it's a very clear serosal detail. Serosa is very clear because this cat has a lot of fat inside the abdomen. So that's why even the gas in the descending colon, you can see the gas in the descending colon is quite appreciable as well. Here there is a gas in the loop as well. So these are mostly the small intestine will be concentrated in the ventral part of the abdomen. This here, ventral and middle part of the abdomen. So this is about. Now let's talk about the normal radiographic anatomy. Normal radiographic anatomy of the abdomen. So first of all, it's very important to take the proper views. So for proper views, minimum I will highly recommend that we should go for 2 orthogonal. Orthogonal means 90 degree. So 90 degree 2 orthogonals means at least lateral view, left lateral, right lateral, or sometimes you have to go for both left and right lateral and ventodorsal view at least. So exposure, try to take the exposure of the X-rays at the end of expiration. So hind leg should be relaxed and not strike too much on the back. So there might be, you might need some positioner under the sternum to avoid the rotation as well as while taking, because sternum is slightly higher placed as compared to the backbone. So that's why you might need some positioner, some cloth, or there are foam positioners are available. You can place that positioner under the sternum so that the sternum and the backbone, they should come to the same level while taking the exposure. So what I will highly recommend, it's ethically what you should do. Once the animal comes and animal has fed recently, then taking the X-ray may not be a good idea. So at least the 12-hour fasting minimum. Enema may be necessary before taking the before exposure, and patient is sustained in lateral and dorsal recumbency, and sedation may be required if the patient is fractious, is aggressive, patient is not cooperative. But the most important part is that 12-hour fasting should be there. That will help you in diagnosis and proper contrast as well. So if you look into this one, X-ray which was taken in a dog with full stomach, you can see there is a lot of food, even intestines are not visible, serosal detail is not visible. When I talk about the serosal detail, it means I'm talking about the outside lining of the intestine. So that outside lining is not clearly visible. So when this dog was called next day after fasting, you can see same dog after fasting, when radiograph next day, you can see clearly. So contrast is very good as compared to the previous X-rays. Even intestine serosal detail, if you see this intestine serosal details are quite clearly visible. Stomach is visible over here as well. So earlier the stomach was not visible. So it is highly recommended, especially if it's not emergency, if there is a GDV is there or diaphragmatic hit by a car and it's a life-threatening problem, then there is no alternative and you have to go for X-rays. But if there is an alternative, you can go for fasting minimum for 12 hours and enema as well, and that will help you in improving your diagnosis as well, and the organs will be visible clearly. And let's come to the another is lateral view. When what you have to see for the lateral view, this is L for liver, and this is a stomach. So if you see, look into the stomach. This is the stomach. This is the body and the fundus part of the stomach, and this part is the pylorus. This portion is the pylorus of the stomach. So if you look into the stomach, so you can see whole of the stomach is within the rib cage. So no part of the stomach is out of the rib cage. Although if animal is fully fed, sometimes some part of the stomach can go because it's a mobile organ, so it can go beyond rib cage. But if fasting is done properly, then whole of the stomach should be within the rib cage. So this is a right kidney, and the left kidney will be visible. And then C for colon, and SI for a small intestine, urinary bladder, and here if you see cecum will be visible as a comma-shaped structure. So that will be just underneath, just caudally and ventrally to the kidney shadow. So cecum will be visible, and this cecum will be more visible when you take a right lateral view rather than the left lateral view. So spleen will be visible at this point as well. So here is the P for pylorus, which I already discussed. The pylorus and the stomach, upper part is a stomach. So when you take the VD view, so stomach, and if you see that this stomach, this is the shadow of the stomach. If this one, so you can see this, here is the last rib. So whole of the stomach is within the rib cage, and if you see the stomach in VD view, it will be almost perpendicular to the backbone. So perpendicular to the backbone. So here you see the cecum on the right side, then small intestine will be visible, then colon will be there. So I'll be discussing more detail later on as well when I'll come to the individual part of the intestines. Then spleen will be at this point, left side spleen will be because the spleen is attached with the stomach as with the gastrosplenic ligament. So that's why they remain in close contact with each other even in the VD view. So now let's come to very important part, that this was about the survey radiography. Well, another important part is that barium series, which will tell you about the mucosal detail. Survey radiography will tell you about the serosal detail, but this barium studies or contrast radiography, that indication. Let's come to the indications first when we should go for the barium study. So if there is a vomiting which doesn't improve with the medication, and there is unclear finding in survey radiography, and ultrasonography and endoscopy is not available, then barium study will be a good idea. Then if you suspect that there is some foreign bodies there, but that is not a radio opaque, it can be a rubber, it can be a plastic, wood, synthetic material, or it can be toys, or even recently we had cotton balls, a carpet, a piece of carpet as well, and there are a number of cloths and rope as well. There is like a jute rope we taken out recently as well. So these type of foreign bodies will not be visible because they are radiolucent in nature. So that's why if you want that we should further go for diagnosis, then barium study is a good idea, especially if these radiolucent foreign bodies are there. Displacement of the intestine segment, especially if there is a herniation is there, and especially in perineal hernia, before operating, you want to judge whether this the herniated portion is an intestinal part, or it's a urinary bladder has herniated, or prostate has herniated. Then what we can do is we can go for barium enema and to see whether the barium enema goes into the herniated part. So that will tell you about the idea of herniated organ as well. Then if there is a suspicion that there is a delayed gastric emptying is there, it means there is some chronic disease is there. So then we can also go for contrast radiography using the barium swallow. So how we can do is, so there is a procedure for that, and when we need to take the x-ray, this is also very important, because giving proper amount of barium sulfate and exposing the animal to x-rays at a proper interval will help you in diagnosis. If proper amount of barium sulfate is not given, then that may not help in your diagnosis. So 12-hour fast, no sedation. There is no, in survey radiography you can go for sedation, but for barium study, sedation is not desirable, because if you give sedation, then even the intestinal movement will slow down, and that can give you the false results as well. So sedation is not recommended. So surveys before giving barium sulfate by mouth, so you have to go for survey lateral and VD views as well. So administer barium sulfate by oral or orogastric tube as well. If animal is cooperative, or even if you know like how to perform orogastric tube, I will highly recommend that go for orogastric tube intubation if you want to go for barium sulfate administration, because sometimes oral, when you give oral, it can spill over and it can apply on the skin, and that will show up in the x-rays as well. So orogastric intubation is more desirable than giving the barium sulfate by mouth. So for the dose rate, it's a 12 ml per kg in small dogs and cats, 7 ml per kg for large dogs, especially the barium sulfate, which is 40% weight by volume. So it's available in the market as well. So right lateral DV, BD views for the stomach. So for the stomach, when you take for the stomach, immediately at means just give the barium sulfate and take it immediately at 0 time to see the to see whether there is a movement of the barium in from the esophagus into the stomach. So, and left and right lateral VD. Then at 0, first of all you have to see which organ you want to highlight. Whether you want to see a small intestine, whether you want to see a large intestine. Accordingly, the time will vary. And if you want to see the esophagus and stomach, then starting from the 0 minute, then take a 15 minute, 30 minutes, 1 hour, 2 hour, and 4 hours. So these are the exposure interval you have to. So if you suspect, this is a very good practical point which I want to discuss with my fellow vets. But if you suspect there is some linear foreign body may be there, because sometimes even owner doesn't know that there can be ingestion of the linear foreign body, and you suspect that there is can be a linear foreign body, or you suspect there is extra GIT gas bubbles are there, out of the GIT gas bubbles are there, then don't give barium sulfate. Then there is organic iodine material which is easily available in the market in the form of gastrographin or urographin, which contain ditrizoate, and this can be given at the dose rate of 1 ml per kg. So that contrast medium can be given if you suspect that there is intestinal perforation is there, because if there is intestinal perforation and you give barium sulfate, so that can lead to peritonitis and that can lead to granuloma formation as well. But if you give this or iodinized material like gastrographin or material which contain ditrizoate, then it will absorb, it doesn't have that side effect. So it's a safe, especially if you suspect there is the intestinal perforation is there. So emptying time, this is also very important. Practical part is that you have to see whether this organ is properly, the barium contrast medium is properly emptying from that particular organ at a proper time. So liquid barium that empties from the stomach by 1 hour in dogs and 30 minutes in cats. It means within 1 hour, in a normal animal, 1 hour, the whole of the barium or I should say 75% of the barium should come out of the stomach and should enter into the small intestine as well as in the large intestine, and in 30 minutes time duration in cats. So at 15 minutes, you should see that the barium should be there in small intestine. At least some part of the barium should go into the intestine, small intestine. In 1 to 2 hours, the barium should enter into large intestine. And rule of the thumb is that iodine contrast material that will empty faster. So it has been seen that if you give iodine, ditrizoate or gastrographin, they might take 50 to 75% of the time which the barium it takes. Means like if the barium that empties from stomach in 1 hour, so that will be 40 to 45 minutes. It will empty from the stomach as well. So it means like it will empty faster as compared to the barium as well. So let's start with the first organ. So which I'll be discussing is the esophagus. So esophagus is the food pipe. So this is the first, like when the food will enter from the mouth into the esophagus, and there is a peristaltic movement is there, and that esophagus will push the food bolus into the stomach. But radiographically, the esophagus is not so clearly visible when you take a thoracic radiograph. It's not so clearly. Sometimes there can be a small gas pocket is visible just dorsal to the trachea. But if you want to highlight esophagus, especially in the condition if you suspect there is some foreign bodies there, or if you suspect there is a mega esophagus. Mega esophagus is a very common condition which the vets they might be getting in their practice. So esophagus and then barium series or barium swallow will be the good idea to highlight the esophagus as well. So when you talk about the esophagus, is not normally seen in survey radiography. So, but if the absence of any abnormal esophagus radiographic finding, it doesn't preclude that presence of, doesn't let you know that it is. So it doesn't preclude the presence of any disease. So then you might have to go for further diagnosis like endoscopy or contrast esophagography as well. So let's come to the first disease, which is megaesophagus, and very commonly presented to the vet clinics, and even at our place we are getting a number of cases. So then first of all, regarding the etiology, it can be congenital in nature, or it can be congenital means like there is a PRRA means like persistent right, PRAA means persistent right aortic arch, which I'll be discussing. So these type of congenital issues can be there, or sometimes there is even the megaesophagus can be congenital in origin as well, and idiopathic unknown region is there, but the puppies they have it. Then it can be in adult onset, means in especially the big size breed, greyhounds are there, or Great Danes or German Shepherd, they can have acquired in later on adult as well, and this can also be idiopathic anorexia as well. Sometimes you don't know the reason what is, but there is a megaesophagus is there. So congenital defects resulting from esophagus, that includes the vascular ring anomalies, means I'm talking about persistent right aortic arch. Then esophageal diverticulum can be there, which can be a congenital in origin. Then myasthenia gravis. So there is a myasthenia gravis, or sometimes it can be idiopathic in origin when the cause is not known. Adult onset megaesophagus can be primary, which can be primary means idiopathic, or secondary to some systemic disease. There are a number of diseases are there which can lead to esophagus, this megaesophagus or dilatation of esophagus. So secondary megaesophagus can be immune mediated. It can be immune mediated as well, especially SLE, systemic lupus erythematosus, or polymyositis. When these are two conditions, polymyositis, when this is immune mediated conditions, and that these conditions can lead to megaesophagus. Then there is some endocrine diseases are there, like hypoadrenocorticism, we call it as a Addison's disease, or hypothyroidism, and diabetes. That these endocrine diseases can also lead to megaesophagus. Then some toxicity, heavy metal toxicity, especially the thallium toxicity. So some of the foods, especially the food which are not properly monitored, and food commercially available food which are not properly monitored by the government agencies, they can have a high thallium in it. So that can lead to megaesophagus as well, and neurotoxin-induced cholinesterase inhibition, that can also lead to these toxicity, means exposure to some these insecticides, that can also lead to megaesophagus. If there is an esophageal stricture or esophageal foreign body is there, so cranial to that stricture or esophagus, where that can lead to dilatation of the esophagus, and that can lead to megaesophagus as well. So there is another condition which is distemper. So because it's a nervous because it affects the nervous system. So disease which affects the nervous system, especially in the puppies, that can lead to megaesophagus. Dysautonomia means a disease which affects the autonomic nervous system, which give the nerve supply to the muscles of the esophagus when it is not proper. So that can lead to dilatation of the megaesophagus as well. So these are the number of conditions. So number of conditions are there. So radiographically, the X-ray will look like the same. For you have to go for further diagnosis, what can be the cause of megaesophagus. But the sign will be the regurgitation. So regurgitation is typical, but you have to see you have to extract the knowledge from the owner, whether you have to differentiate between whether it's a regurgitation or it's a vomiting. Sometimes owner confuse regurgitation with the vomiting. Then you have to ask the question whether there is a bile is there or not, or if there is a bile, it means it's a vomiting, or if it's a cylindrical food is coming out, it means it's a regurgitation. And even you can check the pH of the vomit as well. If it is acidic in nature or alkaline in nature, then it can be from intestine or stomach, that can be a vomiting as well. So you have to judge from the history as well. That premonition sign is very important. Means before vomiting, there is a premonition signs are there. Lot of salivation, then abdominal contraction is there, then straightening of the neck, and then animal vomit. But in regurgitation, there will be no premonition signs will not be there. Excess of salivation will not be there, and retching will be there, and animal will throw out the cylindrical food out as well. This is a regurgitation. Means you have to differentiate. If there is a regurgitation, it means you have to concentrate on esophagus part especially. So is there any, so then you have to, so there is a, when you take an X-ray, especially for the esophagus, especially for the megaesophagus, then you have to see what you have to see in that particular X-rays. So Röntgen signs of megaesophagus is, it will be normally, I told you about that in a survey radiography in a normal animal, esophagus will not be visible. But if there is a megaesophagus, then it can be visible even in survey radiograph, and it can affect the other organs as well in the thorax. Means it can put the pressure on trachea, windpipe as well, and it can put because I told you anatomically, if you recall, that esophagus will be traveling dorsal to the trachea. When it travels dorsal to trachea, and if there is a dilatation of esophagus, it will put the pressure on the trachea, and it will push the trachea ventrally. So means if the trachea is pushed ventrally, then you have to think that it can be the case of megaesophagus. So tubular gas fluid ingesta containing structure within the cervical area dorsal to the trachea is the megaesophagus, and there will be ventral deviation of trachea. This is highly, means I should say, very important point. So I'll be showing you the X-rays as well. So the ventral deviation of trachea is an important diagnostic point for megaesophagus. Wild mediastinum, especially when you take a VD view, wide mediastinum, and tracheal stripe. This is a very important diagnostic feature in X-rays, which tracheal stripe means, as I told you, that the esophagus is dorsal to the trachea. What happens when the megaesophagus is there? Then the fluid and the food, they start accumulating into the ventral part of the inlaid esophagus, and the ventral part of because of the gravity, food and the water, when it accumulates, it start overlapping the dorsal wall of trachea. Means the ventral wall of the esophagus will be overlapping the dorsal wall of the trachea, and it will look like that the dorsal wall of the trachea is thicker as compared to the ventral wall. So this is called tracheal stripe. So I'll show you the X-rays as well. So thickening of the dorsal tracheal wall due to superimposition aspiration of the ventral wall of the gas filled or fluid filled or food having a food in the esophagus, so that will show up as a tracheal stripe. So if you look, mostly it will be associated with respiratory pneumonia. Aspiration pneumonia will be visible in lungs, especially in the cranial part of the lungs, cranial and ventral part of the lung lobe. They will have the aspiratory pneumonia signs. And why this is aspiration pneumonia? Because of the chronic regurgitation. When there is a chronic regurgitation, then the part of the food or part of the liquid or fluid, it can go into the windpipe as well, and that will settle down into the lungs, and that can develop as a aspiration pneumonia. If you look into this X-rays, if you look on this X-rays, so this is a typical X-ray of megaesophagus. This is generalized. So generalized means whole of the megaesophagus is whole of the esophagus is analyzed. So if you look into this one, this is the tracheal stripe. If you see, let me highlight this one. If you look into this part of, so there are two walls are there. There is a part. The part which I highlighted as a yellow lines, this is the dorsal wall of the trachea, and the wall which I highlighted as a white line, this is the ventral wall. You can see the dorsal wall. Here you see then the plain survey radiograph. The dorsal wall looks that it is thicker than the ventral wall. This is called tracheal stripe. So tracheal stripe is a diagnostic point for megaesophagus. And the heart, if you look into the X-rays and even you refer my first webinar, so you can see that heart, the dorsoventrally, the heart will be the shorter as compared to the normal animal. Why? Because there is a constant pressure from the esophagus, dilated esophagus from the dorsal side. It will continue to put pressure on the heart. So heart will be shorter dorsoventrally, which is seen in the cases of megaesophagus. If you see this, so dorsoventrally, if you see the diameter of the heart has reduced. And there is aspiration pneumonia. There is a pneumonia signs will be there, especially in the cranial part of the lungs. You can see there is an increased radiopacity, and even there is a lot of small dots, radiopaque dots. This is typical sign of aspiration pneumonia as well as an infection in the cranial lung lobe. And here, if you see that aorta, this is what I right now I'm highlighting as a red lines. This is aorta, and if you see the blue line, which this is the caudal vena cava. And even you see it is separated from each other. Normally, this big space is not between aorta and this vena cava, caudal vena cava. This space, they are separated from each other because there is a big esophagus in between, which has pushed the aorta dorsally and this caudal vena cava ventrally. So that space, when there is increased space between aorta and caudal vena cava, and the tracheal stripe is there. So this is a diagnosis for generalized megaesophagus. So there is a widening. There is a widening. If you see, there is a VD view. So here you see this is the mediastinum. This is a mediastinum. So I told you in the previous lecture as well, the mediastinum, all the thoracic organs, they except lungs, they are present in the mediastinum. Heart will be there in the mediastinum, esophagus, trachea, lymph nodes are there. So all these organs they are present. But the lungs, they are present in the pleural cavity. So because the esophagus is present in the mediastinum, so that's why, because of the dilatation of the esophagus, so there will be a widening of the mediastinum. So widening of mediastinum, you can see it's all there. Let me highlight. If you see, you can this one. So all this means cranial, middle, as well as caudal mediastinum, all are allied. This is a typical sign of generalized megaesophagus. If you go for contrast, if you see the contrast medium, so the contrast is going, it is going beyond as well. So this can be another diagnostic. You can add on to your diagnosis by going for barium swallow or contrast radiography. So this will add up you to your diagnosis as well. So this is another case of megaesophagus. This was a case which is having a severe megaesophagus with marked enlargement of esophagus is there. But this case has a mild to moderate megaesophagus is there. If you see in the neck region, like I'm talking about this one. see about this one. So there is a cervical enlargement of esophagus. Cervical portion of the esophagus is enlarged as well. So if you look into this one, so this is the caudal part of the same animal. If you look into this one, so there is megaesophagus is there. If you see the megaesophagus, it's clearly gas bubble, this tubular gas bubble is visible. So this is a generalized megaesophagus is there. Even you can see at this point, you can see the megaesophagus, and even the black arrows, you can see there is a aspiratory. Because of aspiration, there is a lung congestion is there as well, and the right middle lung lobe especially, it has a congestion, and there is aspiratory pneumonia is there as well in this particular. It means you have to take care while managing this esophagus, means you have to give antibiotics for a longer time as well as antacids as well for longer time, so that to clear the aspiration pneumonia as well. So repeatedly X-ray has to be taken to see whether the lungs are cleared. So megaesophagus you have to manage by the management only, but the aspiration pneumonia you have to take care with antibiotics and other drugs as well. And here if you see there is a dilatation. If you clearly see there is a dilatation of mediastinum as well because of megaesophagus. So there is now comes to the that was a generalized megaesophagus. Now comes to there is another condition which is localized. Localized means a part of esophagus is dilated. So which is very commonly found in vascular ring anomaly, which is called persistent right aortic arch. So this is extraluminal esophageal stricture is there, means from outside that doesn't have anything with the luminal part. Extraluminal means outside there is some stricture is there which doesn't allow the dilatation of the esophagus properly, proper contraction or the passage of food through esophagus is not proper. So that is the extraluminal esophageal stricture is there. So persistent right fourth aortic arch, which is most commonly involved as a vascular ring. So at our institution, almost 1 to 2 cases every 1 to 2 months they come these conditions, and we perform the surgery. We open up the thorax, and then even we cut these rings as well, and animals they respond really well to surgical treatment. And esophagus is enclosed in a ring which is created by the trachea, aorta, main pulmonary artery, and ligamentum arteriosum. So this is the problematic ligamentum arteriosum. This is ductus arteriosus is there. So that is means through this ligamentum it is viable in fetal birth. So there is a proper blood supply is there. Immediately after birth, that ductus arteriosus convert in that breaks down, and that will. But if it remain persistent after birth, then that will convert into ligamentum arteriosum, and that will form a ring along with the trachea, aorta, main pulmonary artery, and that will constrict the esophagus and will not allow it properly dilate, and this will result into dilatation, marked dilatation of esophagus cranial to the heart. It means, as I told you, this is a persistent right aortic arch. It means that the problem is just dorsal to the heart. When problem is just dorsal to the heart, stricture is there, so dilatation is not there of the esophagus, dorsal to the heart. So whole of the esophagus, which is cranially, means there is a localized dilatation cranial to the heart. So stricture of the esophagus at the base of the heart. So no or minimum dilatation will be seen caudal to the stricture. This is another important point to differentiate whether it's a generalized or because of the dilated megaesophagus, because of the vascular ring anomalies. So beyond heart, there will not be a dilatation of esophagus. So in lateral view, trachea will be pushed markedly downward, and it will dip downward suddenly between the thoracic inlet and the heart. So I'll show you the x-rays, what it means. Then there will be aspiration and pneumonia as well. So if you look into this one, if you look, let me show, highlight the trachea. If you see the trachea, you can see the trachea, just this is trachea. Just dorsal to trachea is the tracheal stripe, and here you see the heart shadow. So just see, just cranial to the heart shadow, the trachea is pushed markedly downward. This is a typical sign of megaesophagus because of the vascular ring anomalies. So same, if you see the VD view, if you see there is a big gas bubble is there, which is visible. So this is a typical sign. You can see hard shadow is there. Here is the hard shadow. This one is the hard shadow, just cranial to the hard shadow, in between the thoracic inlet. So here is the thoracic inlet. Here is the thoracic inlet. In between the thoracic inlet and the cardiac shadow, there is a big gas bubble esophagus containing a big gas bubble. This is a typical sign of localized megaesophagus because of the vascular ring anomaly. So if you go for a contrast, you can see the contrast means whole of the contrast has accumulated just cranial to the cardiac shadow. It means whole of the at this point it means that this is a mega. So beyond this one, here you see there is a stricture is there. Some part of the barium has gone into the stomach, but the dilatation is not visible beyond. Means I'm talking about this portion beyond cardiac shadow, dilatation is not visible. So that's why this is a localized megaesophagus because of the vascular ring anomalies. So here you see, you can differentiate between generalized megaesophagus and localized megaesophagus. In generalized means contrast medium is going beyond the cardiac shadow. But in localized, because of the vascular ring anomaly, the contrast medium is not able to pass beyond cardiac shadow as well. So this is another esophageal diverticulum along with the megaesophagus. So now comes, this was about the megaesophagus. Most of the time the X-ray will show like that. So etiologies I have already discussed. So you have to see why there is a problem. So most likely it can be because of, especially in the old age dogs, because of hypothyroidism, hypoadrenocorticism, or even electrolyte imbalance. Like if there is sodium or potassium deficiency is there, and potassium is required for the muscle contractility as well. So that can also lead to the megaesophagus. So electrolyte imbalance has to be checked. Electrolyte estimation has to be done simultaneously as well, and endocrine estimation, especially in the old dogs as well. So let's come to the second disease, that is the esophageal foreign bodies. So radiographically, there will be a radiopaque. If it's a radiopaque, it will be visible, can be seen. And if it's a radiolucent, then dilatation of esophagus cranial to the obstruction can be visible. So, but if there is esophageal perforation is there, then that can lead to mediastinitis or pneumomediastinum as well. So you have to see whether if there is a pneumomediastinum along with the foreign body in the esophagus, it means that is the cause. It means there is a esophageal perforation or esophageal rupture is there as well. So then you have to proceed the case accordingly as well. So if you look into this one, so there is a typical, this is the esophagus which has chicken bone stuck in the caudal part of the esophagus. I'm going to highlight this portion in the next slide. If you see, so there is a chicken bone is there. So this chicken bone is obstructing the esophagus, and that is leading to the chronic regurgitation as well in this animal. And there is some, here you see this portion, I'm talking about this one. So there is some foreign body is there in the esophagus, which is surrounded by the gas bubble. Here you see. So this gas bubble, so because the foreign body is pressing, you can see even the full foreign body, this is pressing the trachea as well. So here you see there is some radiopaque foreign body is there in the caudal part of the, so these is all foreign bodies are there. And even you can see the foreign body which led, and as well as pneumonia as well. If you see the black arrows, these black arrows, so around these black arrows, this part of the lung has a pneumonia as well. So this is because of the chronic regurgitation and esophagus as a foreign body. You can see, I'm again highlighting with the yellow lines that these esophagus as well. So these are the pneumonia signs. If you see the black arrows, these are all pneumonia signs, because this foreign body is radiolucent in nature. It's not radiopaque, but because it is visible, even you can give barium sulfate as well to highlight this foreign body as well. And this pneumonia sign will be visible because of chronic regurgitation. So this was a case in which the cotton cloth was there as a foreign body, which has gone into the esophagus. So then we have to perform the gastrotomy, and from the stomach we pulled out that cotton cloth. It was a towel called cotton cloth. So you can see the cotton cloth, and when we gave the barium, so that barium has percolated into this cotton cloth, and that has gone. So it can be a good idea to go for even the contrast radiography, especially if there is no pneumomediastinum, means pneumomediastinum should not be there. And if you want to see about the pneumomediastinum, just see my last webinar. There I have discussed about the pneumomediastinum as well. Now comes to the esophageal masses. So because I told you it's a hollow organs, almost all part of the digestive tract, they are prone to the masses, they are prone to neoplasia, they're prone to the granuloma formation, they are prone to the abscess formation as well, or there is some cyst formation. So these are called masses. So first of all, let's discuss about the esophageal masses are there. So this is, although like neoplasia of the esophagus not so common, but I should say in my practice, so I have seen around 15 to 20 squamous cell carcinoma of esophagus as well. So not so common, but it can be there as well. So usually it requires esophagogram, means the contrast radiography has to be done to diagnose. So granuloma, spirocerca is more common in our place, at our place in India as well. So that can form a granuloma, and that will show up as a esophageal mass. And this spirocerca lupi, this will form a granuloma into the wall of the esophagus. So it will form a, so you can see, so there will be a retention of the, because of that granuloma, it will obliterate the lumen of the esophagus. So barium paste will not able to pass thoroughly. So that will lead to the megaesophagus as well, and it will accumulation of the barium paste cranial to that mass. So barium, and there is another very important term which I'll be discussing quite frequently in my webinar. This is called filling defect. Filling defect is when you gave the contrast medium, and when that contrast medium is not able to reach at a particular place where it should be there, it means that's a filling defect. And that filling defect is an indication that there is some mass is there, and mass doesn't allow the barium to go to that particular space. That is a filling defect. So if you see, this is a case of spirocerca lupi. So if you see, this is spirocerca lupi is there. So when contrast medium was given, so there is a contrast medium. So observe the filling defect. Observe, this is a filling. These are the filling defect. Means like you can see in a normal animal, when you gave the contrast barium, so it should make a very good structure as a hollow structure, tubular structure, and it should go up to the stomach. But you see, if you see, here is the heart. Here is the heart, just dorsal to the heart, up till here, the barium is going, and beyond that, there is a filling defect is there. Means beyond that, the barium is not able to percolate. It means there is some mass is there, which doesn't allow this barium to move, to go through it. So this is called filling defect. So there is another, this is another esophageal mass. You can see here is the esophageal. This is a survey radiograph of esophageal. So you can see there is a soft tissue density. So this one, yellow lines and yellow arrows, this shows the soft tissue density just cranial to the diaphragm. So this is the esophageal mass. So observe the filling. You can see, observe the filling defect. When we gave the contrast, you can see that on this red portion of the esophagus, the barium can't enter. It is only going through some part of the barium is entering through the ventral part only. It means this is called a filling defect. So filling defect is there, and this filling defect is a diagnostic I should say character in contrast radiography if there is esophageal or a mass anywhere. Even in the later part of webinar, I'll be discussing about the filling defect in stomach as well. So this is a characteristic sign that there is some esophageal mass is there, which is not allowing the barium to percolate inside as well. Now comes to the another disease which will look like a esophageal mass. It is called esophageal hiatal hernia. Hiatal hernia means there is esophageal, hiatal esophagi is there, through which in the diaphragm there is one opening is there through which the diaphragm enters from the thoracic cavity into the abdominal cavity. So through that opening, this is called hiatal esophagi. But if the opening, that opening is bigger than normal, and then some part of the stomach can enter through that opening and it can enter into the thoracic cavity. This is called hiatal hernia, and contrast radiography can help you in diagnosis as well. So stomach that will herniate through diaphragmatic esophageal hiatus and will enter into the esophagus. I'll show you in that how the X-ray will look like in this condition. Maybe sometime it's intermittent, sometime with contraction of the stomach, sometime it enters and sometime come back, sometime enter into the thorax, and next time it come back to the into the abdomen. So this can be there. It is called sliding hernia, or it can be a fixed hernia as well. The sign will be the same. It will be a regurgitation. Lot of regurgitation can be there. So whenever animal eats, within half an hour, animal throws out. And when you take an X-ray, so it will look like there is some mass is there, especially in the just cranial to the diaphragm. So there is a Röntgen sign will be there. The caudal mediastinal mass in the area of esophagus, just cranial to the diaphragm. On esophagogram, the gastroesophageal junction, just cranial to the diaphragm, will be visible. So let me show you here. Here is the picture diaphragm. If you see this one, this is the diaphragm. So there is a hole is there. So this hole, this is the hiatal esophagi, through which the esophagus will enter from thorax into the abdomen. So if you see, so there is a peritoneal covering is there. So that peritoneal covering will form phrenico-esophageal ligament, which doesn't allow the stomach to enter into the esophagus. But sometimes there is a relaxation, or there is the relaxation of this ligament is there, and there is opening. This hiatal opening, esophageal hiatal opening is bigger, so part of the stomach can enter into the thoracic cavity as well. And there is a cardia of the stomach is present in the thoracic cavity. There is a gastroesophageal sphincter which should be in the abdomen. It will be seen in the thorax as well. So you can see normally it should be like this. If you see the red line, normally it should be like this. Esophagus should enter up to the abdomen, but cardia should be here. Cardia should be at this point normally, but when it happens, cardia enters into the thoracic cavity. So here you see when you see some soft tissue density. So soft tissue density, if you have a clearly view, so soft tissue density which is visible just cranial to the diaphragm. So on caudal mediastinum part, so this is the hiatal hernia. So from X-ray, it looks like a esophageal mass. The number of questions might be there in the participants that the same X-ray was there when esophageal mass I was showing. That yes, hiatal hernia and esophageal mass will look like the same in survey radiography. But when you perform the contrast radiography, here too is the hiatal hernia. Here too is the hiatal hernia. But when you form the contrast radiography, then you will not see any filling defect. Then you will see that esophagus is there. Then there is a gastroesophageal junction is visible. Then the part of the stomach will be seen in the thorax. So if you see, here is the X-ray which I already discussed. So this was the lower X-ray. This is the esophageal tumor. There is a filling defect is there. Survey radiograph, both of them will look like the same, but contrast radiography will help to differentiate whether this caudal mediastinal mass is because of the hiatal hernia or because of the esophageal tumor or esophageal mass. So filling defect will not be there in the hiatal hernia. So this is an important point which I want to highlight right now. Now comes to another point, which is a diaphragmatic hernia. So you can see like a number of hit by car, sometimes fall from height, fight with other dogs. Sometimes there is even owner sometimes doesn't know they pets, they remain unattended, they fall from the stairs and they come up with the diaphragmatic hernia, and X-ray will, when we perform the X-rays. So first of all, let's come to some part of the let's discuss about the diaphragmatic hernia. Mostly it's a traumatic but you must differentiate between diaphragmatic hernia and there is another hernia which is congenital peritoneo-pericardial diaphragmatic hernia. Two types of hernia can be there. It can be acquired in the form of trauma, or it can be a congenital in small, especially in the small puppies and the kittens, which is called congenital PPDH, peritoneo-pericardial hernia. Radiographically, we can differentiate. So how there are some radiographic characteristics are there, which I'll be discussing in next few slides, that how we can differentiate whether this hernia is because of the acquired traumatic in origin or it's a congenital peritoneo-pericardial diaphragmatic hernia. So muscular portion of the diaphragm is mostly involved. There is like muscular and tendinous part of the diaphragm is there, but mostly the muscular portion is involved. Traumatic acute diaphragmatic hernia can be shown up as a respiratory distress. But chronic diaphragmatic hernia, here we some, so in last, I should say 3 to 4 months, I have come across few dogs, which the owner was not knowing that that there is anything like diaphragmatic hernia is there, and only they came with the history that whenever animal eat the food, and after eating the food animal start feeling discomfort, doesn't sit, and started having a respiratory distress, and when we took an x-ray, then that came out to be a chronic diaphragmatic hernia as well, and mostly it can be an incidental findings as well. And chronic DH, diaphragmatic hernia will be present as dyspnea, exercise intolerance, anorexia, vomiting, diarrhea, weight loss, pain after ingestion of the food, or sometimes depression as well. You can see the variability, how much variation of the sign can be there. So that's why whenever it comes like that, even then taking an X-ray is a good idea as well, because diaphragmatic hernia may be one of the cause of these signs as well. So let's come to the diagnosis part. So liver is the most commonly herniated organ because liver that is directly in contact with the diaphragm. So whenever there is some rent is there, so that liver will enter first organ that will enter into the diaphragm, into the thoracic cavity. Sorry, that can be the liver. And sometimes if it's a chronic, when chronic liver herniation is there, then it protein synthesis will not be proper. As you know, the liver is meant for the protein synthesis. Functioning of the liver will be less as compared to, so protein synthesis is not there, that can lead to even hydrothorax as well. So there will be fluid accumulation in the thorax as well because of the entrapment and venous congestion of the heart as this liver as well. Any organ can be herniated. Recently I operated a dog in which right kidney has herniated into the thorax. So radiographic along with other organs, I'll be showing you the x-ray of that dog as well, along with the intestine, stomach, even right kidney has herniated into the thorax. So radiographic signs that include the loss of radiographic silhouette, presence of the gas or the barium. Even if you go for contrast, then barium filled GIT in the GIT tract in the thoracic cavity will be visible as well. Ultrasound, they can help to diagnose if only small portion of the liver is involved. If you suspect there is a very small amount of herniation, a very small herniation is there, and very little amount of herniation is there, and you are not able to diagnose with a survey radiography or even with the contrast radiography, then even you can go for ciliography as well. What you can do is same iodine ditriazolate or gastrographene or urographene, you can directly inject into the peritoneum and lift the hind quarter of the animal and keep it in that position for 3 to 4 minutes, and then take the x-ray, and if that dye from the abdomen has gone into the thoracic cavity, it means there is a small rent is there. So that is called positive contrast ciliography, which is a diagnostic, especially where even ultrasound fails, or even when you suspect there can be a very small rent is there in the, so positive contrast ciliography using iodine contrast medium can be a good idea to diagnose as well. So we have to differentiate between DH and PPDH, which I'll tell you later on. So this is a typical traumatic. This is a traumatic acquired. You can see here the organ, mostly liver, small intestine, stomach, omentum, sometimes kidneys. You can see the small, you can see here the small intestines. They are visible into the thoracic cavity. And even you can see the stomach. A part of the stomach is in the thorax and the part of the stomach is there in the abdomen. Means if a part of stomach has crossed that rent and part is there in the, and there is a gastric rugal fold are there is visible as well. It means part of the stomach has gone as well, and even intestinal these loops are visible. But what you have to see is, so you can see there is a hardly you can see the diaphragm. So diaphragm is not visible. So what you have to see is, so you have to look into the trachea. How the trachea is traveling, whether trachea is traveling caudally and ventrally or it is traveling other way around. So I'll be showing you. If the trachea is traveling like a normal course, caudally and ventrally, then it means it's a DH. Traumatic DH or DH of any region. But if it is traveling dorsally, which I'll be showing you later on as well in X-ray, so this is a differentiating. Course of trachea will be the differentiating point between traumatic DH and PPDH as well. So let me show you, there is another case. This is another case which I told you that I operated recently, in which the kidney was there. So here you see the descending colon. Descending colon has gone, here you see the descending colon has gone into the thoracic cavity as well. So descending colon, you can see it's a very big rent was there, and this big rent was on the radial part of, radial and dorsal part of the diaphragm. And that previous one was on the ventral part of the diaphragm. Even from X-ray, you can judge whether this rent is there in the ventral part of the diaphragm or in the dorsal radial part of the diaphragm as well. So here you see, the thoracic, same dog, previous this one, so same dog. So you can see the trachea. The trachea is traveling like a normal, and here this one, this is a pre-operative diaphragm. You can see the diaphragmatic line is not visible, but when we operated and when we after operation surgery, you can see the diaphragmatic line, same dog, diaphragmatic line is clearly visible after surgery. So when we took out all the herniation into its normal position, when we sutured the diaphragm, so it looks like there is some pneumothorax is there. Means pneumothorax, although it's there, then we aspirated the pneumothorax, and that also resolved. But you can see this is you can see here, you see before surgery diaphragm is not visible clearly, but after surgery diaphragm is clearly visible. So this is how you can even differentiate preoperative and postoperative, whether proper surgery has been done or not. Even in VD view, you can see the diaphragm is clearly visible. So postoperative X-rays of diaphragmatic hernia for the same dog. So this is the X-ray of PPDH. Peritoneo-pericardial hernia. Now observe, now see the course of trachea. Now trachea is not traveling ventrally, caudally and ventrally, it is traveling caudally and dorsally, and almost touching the ventral aspect of the thoracic vertebrae. And when, so this is PPDH. PPDH basically is a congenital problem in which the closure of the diaphragm is not proper in prenatal birth, before birth. The diaphragm is not able to close properly at its midline, and that part of the rent start communicating with the pericardial sac. So slowly and slowly, when the animal, after birth, the intestine, they will start entering through that rent into the pericardial sac. That is called PPDH, peritoneo-pericardial. It's not in the pleural cavity, it's not around the lungs, but it's around the heart. So that's why when the pericardial sac is dilated, so when that dilated pericardial sac will push the trachea dorsally, and that will lead to dorsal displacement of the trachea, which is a differentiating point between simple DH and PPDH as well. And even you can see here the this herniated part is within the pericardial sac. It has not gone into the pleural cavity. You can see this is a picture. If you see this picture, you can see the intestine, it has gone into the pericardial sac, not into the pleural cavity. So here you can see that this course, see the course of trachea. Now you can differentiate between simple diaphragmatic hernia and PPTH, just looking at that how the trachea is traveling inside the thoracic cavity. So this is another PPDH. You can see PPDH. There is an enlarged gastric silhouette. This is not enlarged gastric because of any cardiac disease. It is all because of pericardial hernia. And even we can see some of the gas pockets. These gas pockets are visible because intestines are there. So there will be a dorsal elevation of trachea. So overlap. So discontinuity of diaphragmatic line as well. So there will be gas-filled structure will be there in the pericardial sac. So this was about the diaphragmatic hernia. Now comes to the another second part, which is the stomach. So stomach is very important part. Because whatever the food that will come from the food pipe, it will enter into the stomach, and there the mixing of the gastric juices happens. So if there is any problem is there, any obstruction or any obstructive lesion, or there is some restrictive lesions. I told you in the beginning, there can be obstructive lesions or restrictive lesions can be there. Those obstructive lesions can lead to a number of signs like vomiting, especially for some vomiting. So radiography can help you in the diagnosis as well, that whether it's obstructive lesions or it's a restrictive lesion is there. Stomach. So another important point is you must anatomically. So when if you look into the anatomy, so fundus and the cardia part of the stomach is on the left side of the abdomen, and pylorus will be on the right side of the abdomen. So when you take a left lateral view, so ultimately when you make the animal to lie down on the left lateral view, so ultimately the so fluid and the food will enter into the will go through gravity. It will go into the fundus, and air will rise into the pylorus. Same way, if you take a right lateral view, when you take a right lateral view, making the animal to lie down on the right side, then what will happen? The right part of the stomach is pylorus. That will become a dependent. When it will become dependent, then fluid and food will enter into the pylorus. Then gas will go towards the fundus as well as cardia, and food will. So same way, the X-ray impression of the stomach will vary according to the recumbency, whether it's a left lateral recumbency or right lateral recumbency. I'll show you. So never try to misdiagnosis basis of any fluid or food either in the pylorus or in the fundus. Or so if you look into this image, so you can see the fundus and the pylorus. You can see here, this is the midline, the backbone, midline. You can see the pylorus will be towards the right side. So this is the left side so this is the right side of the animal. So pylorus will be on the right side of the animal. But if you look into the cat, then most of the stomach, means even fundus and pylorus, they will remain in the left part of the stomach. So pylorus rarely move. In case of cats, pylorus will rarely move towards the right part of the stomach, right part of the midline. So this is a differentiating point when you look into the X-ray of the dog and the cat. So pylorus, whole of the pylorus will be in the left side, but most of the pylorus will be on the right side in dog, and most of the whole of the pylorus in cat will be on the left side. So if you look into left lateral, if you see if the left lateral means when left lateral is there, then this pylorus being on the upper side will have an air bubble inside. And when you take a right lateral, then pylorus, same portion will have a fluid and the food. So that will look like a round structure. It will not have a gas bubble in it. So this is a differentiating point. Even looking into the X-ray, you can. So never misdiagnose any ball or foreign body just looking into right lateral view. If there is any radio opaque or some semi-opaque visibility is there in right lateral, if you suspect there is some ball is there, some foreign body is there, then take a left lateral view and then differentiate and see if the same gas gas pocket is there in the left lateral, it means this is a normal X-rays. So you can see, don't make a mistake of operating to remove a non-existent ball in the stomach, in the pylorus part, because of the recumbency. You can see this is not a ball. This is normal fluid and the food because of the right lateral recumbency. So here you see, so when you stomach will be visible over here. You can see stomach will be visible. Whole of the stomach will be visible in the rib cage. And you can see this is axis. This is a gastric axis which will be perpendicular. So here you see the stomach. Here you see the stomach. Stomach will be perpendicular to the backbone as well. So if you see the feline stomach, so feline stomach, here you see the stomach, feline stomach, and there is a big, large falciform fat pad will be visible just ventral to the stomach. Here you see, this is the contrast you see as I shown you in the few slides back. The most of the part of the stomach of the cat will be there in the left part of the abdomen. You can see that J-shape stomach is there. So this is a normal. Don't take it as a abnormal. Pylorus will be superimposed on the right side of the spine as well. Let's come to the contrast X-ray of the stomach gastrogram. So if you want to go for a gastrogram, overnight fasting must for before gastrogram, cleansing enema, both one night before and the day of study can be done, or on the day of the study, cleansing enema is sufficient. Avoid sedation. Liquid barium sulfate 40% weight by volume is recommended. 12 ml is dose 12 ml should be sufficient, but as inadequate volume can lead to error in diagnosis. As ventrodorsal, all these views can be taken. So gastric emptying, as already discussed, they start at 15 minutes and that will be completed. Whole of the completed within 1 to 4 hours. So now comes to the disorder of the stomach. Disorder of the stomach is like foreign bodies, displacement of the stomach, GDB, which is very commonly, especially in the deep chested and big dogs. So how to diagnose? Then there is a chronic pyloric obstruction. So pyloric stenosis is there. Gastric neoplasia can be visible. How the X-ray will look like, how the contrast is going to help you in diagnosis as well. So if you see the gastric foreign bodies, last comes to these are the radio opaque. You can see the spoon as well. You can see the pins and the nails. And even the stones, they can be the radio opaque, they can be visible easily, radio opaque. But there are sometimes there are hair balls. Number of hair balls are coming across. Sometimes, especially the dogs, they have a habit of eating or licking themselves, or they can eat the hair grass as well. Hair ball as hairs as well. So you can see in the black arrow, if you see, it looks like a food inside the stomach. But this is not a food, it's a hair ball is there. Had it been a food, then it would have been in contact with the stomach wall. You can see this is separate from the stomach wall. So this is not in contact. Another thing you can do is, then you keep it off feed overnight and repeat the X-rays. If this is a food, then it will be empty. The stomach will be empty. But if the same impression is visible next day as well, then most likely this is a hair ball or some cloth is there in the stomach. So hair ball, this was a hair ball which has a smooth margin and they may not be in contact with the stomach wall. So food material has an irregular margin, usually in contact with the stomach wall. But these hair balls, they don't disappear on after fasting next day. If you after 12 hours, if you go for another X-ray as well. There are some semi-opaque foreign bodies as well. You can see these semi-opaque foreign bodies. So which was operated, and these are the toys. These are semi-opaque foreign bodies as well. So even you can go for gastrogram as well, means contrast radiography. If the gastric foreign bodies like cloth, this is a very important slide which I want to discuss with my fellow vets. Sometimes sometimes the owner says that my socks is missing. I suspect that my dog or cat has eaten the socks. But when you take an X-ray, then you don't come to any final conclusion, because these socks are radiolucent in nature, not radio opaque in nature. And these cotton or sometimes even carpet is there. So these are not clearly visible in X-rays. Then you can go for gastrogram. So that will be be a better diagnostic technique. What you can do is you administer 25 to 30 ml of barium sulfate and try to coat. Means cloth, they have a tendency to percolate. They try to absorb the liquid. So when they absorb the liquid, automatically the barium will also be absorbed into the cloth or the sock. So when it will absorb, so then you take the 4 projection after 60 to 90 minutes. So means when you give barium and wait for 60 to 90 minutes. So part of the barium will percolate, will be absorbed by these cotton material, cloth, sock or carpet, but rest of the barium will go towards the intestine. But whatever the barium will be absorbed by the cloth or by these cotton material, it will remain inside the stomach. So the fabric, rag, socks may not create an initial filling defect, but when the barium will percolate into it, and it will be better visible when rest of the barium will move forward. I'll show you the x-rays, and then you will be able to understand properly. This was a cloth, a towel was there in the stomach. So, but it looks like a food even, but it looks like a hairball as well. But when the stomach, you can see it like when barium was given, 25 to 30 ml barium was given. So that barium, it percolated into this. Then after about 1 hour, you can see the barium which has percolated, which is absorbed by these socks, it remain within the stomach after 1 hour, and rest of the barium, it has gone into the stomach, into the intestines. So this can be a differentiating point. Yes, there is some cloth or something is there which has absorbed the barium, and it has absorbed the liquid. So you can see after 3 hours, after even 3 hours, the same contrast medium remain within the stomach. So this is a very good diagnostic aid, gastrogram, especially when radiolucent material is there as well. And owner, as per history, there is some cloth or sock or some synthetic cloth is there, so which can percolate the liquid. So then you can even differentiate as well. This is a carpet. This is a carpet which animal has eaten, and the same technique was used to diagnose even as well. So after even 1 hour, after 2 hours, or even after 4 hours, whatever the material which is percolated, absorbed by these cloth or socks or carpet will remain inside the stomach. It will not move, but rest of the material, rest of the barium will move into the small intestine. Let's come to the very important part, is gastric dilatation, GDV, gastric dilatation with volvulus. So very common disease, especially it is a common disease in deep chested, but there are few points which I want to discuss. So practical points is mortality rate is quite high in 20 to 45%. For 45% mortality is there because it depends upon when it is presented to the hospital. So if it is present earlier, then chances of survivability is more. But if it is more presented late, then because of a GDV, some necrotic changes or ischemic changes can happen in the GDV gastric walls as well as in the spleen, so that can be fatal as well. Dogs operated for splenectomy, this is very important. If splenectomy is done in any particular dog with spleen mass or spleen tumor is there, angiosarcoma of the spleen is there, then if you operate for that one, then that dog will be prone to GDV due to lack of gastric stabilization by the gastrosplenic ligament. So gastropexy is highly recommended after splenectomy. This is a practical point which I want to discuss. Sometime it comes that splenectomy was done after 6 months or 1 year, that dog can have GDV as well. So that's why gastric gastropexy should be done in such cases. In addition to the deep chested, GDV has been reported in cats as well as small size. It was earlier in the literature. Now it's there in the literature. It's not only the disease of deep chested. It can happen in cats and the small size breed as well. So can occur in any age, but most commonly it's middle age on old dogs. So when the animal which are fed dry kibbles from elevated food bowl at height, and they are very anxious, especially the Labradors, which are very anxious, they try to finish the food very quickly, then those dogs, they are prone to GDV. Indoor dogs which are spending 5 hours or more with the owner appear to be a risk with the risk of GDV as compared to the dogs which are playing outside with other dogs. This is another study, very interesting study and very effective. It has been seen the dogs which are active and play outside, they are less prone to the GDV as compared to dogs which are remain inside for more than 5 hours with the owner indoor. They are prone to GDV as well. You can educate, like looking at these practical points, you can educate to the owner that how to feed and why there is a need for exercise, especially in the dogs to prevent GDV, especially the big size or Dobermans or Great Danes, which are prone to GDV. So this is an X-ray of GDV. If you look into this one, so if you see that the pylorus, I told you the pylorus should be at this point at the ventral side, but if you see this is a duodenum, even the duodenum is present at its abnormal place. So you can see here, here you can see that this one, these two circles. The upper one, this is called double bubble appearance. Reverse C-like. The upper bubble is pylorus. The lower bubble is the fundus and the body. Fundus and the body. The same way the VD view, if you look into this bubble is the fundus and the body, and here is the pylorus. You can see this is the left part, left side of the abdomen. This is the right side of the abdomen. Pylorus has to be on the right side. So GDV, when GDV happens, it moves towards the left side and dorsal side. So that leads to gastric dilatation of the volvulus. So this is a typical sign, double bubble appearance. Pylorus is there. So here another. So you can see double bubble appearance. Same way you can see this one. So this is the pylorus, this is the fundus and the body. So why right lateral is more diagnostic? This is another point. Sometimes that even in the students, they ask me that why right lateral is only to be done. You see that difference. I'll show you the difference. This is a right lateral view of a dog affected with GDV. And the same dog, when left lateral was taken, you can see the difference. This is not diagnostic. The same dog, this is the right lateral, which is diagnostic for GDV. Same dog, when left lateral was taken, this is not diagnostic. That's why the right lateral view is highly diagnostic, is recommended, highly recommended for the animals which are having GDV. So this was about GDV. Now comes to the another disease, which is gastric outflow obstruction. So especially the dogs which are middle to older age, which are having a history of chronic vomiting, and you suspect there can be a pyloric stenosis or there is some tumor, gastric tumor, adenocarcinoma is a common tumor in dogs, and lymphosarcoma is a common gastric tumor in cats. So that can lead to gastric outflow obstruction. So chronic means it can be restrictive or obstructive. So I told you that there are two diseases are there which are chronic in nature. It can be restrictive. Restrictive means when the lesion is in the wall of the organ. When the wall of the organ they thickened. When they thickened means passage is narrowed down. That is restrictive. Means restriction is there, but passage is there, but there is with some restriction. Obstructive means there is complete obstruction of the passage. Complete obstruction of the passage because of the foreign body, because of the tumor. So restrictive is mostly related with the wall problem, stomach wall problem or intestinal wall problem or esophageal wall problems. That is restrictive in lesion. So passage of food, passage of contrast will be there, but with restriction. Both can't be distinguished on survey radiography. You can't differentiate on survey radiography. So survey will show the dilatation of that part of the stomach with the fluid or air as well. Contrast medium that can help you to diagnose because there will be delayed. I told you that the barium will start emptying from the stomach in 15 minutes. Within 1 hour, 1 to 2 hours, I should say 1 to 2 hours, whole of the barium should pass from the stomach. If it's not, means most part of the stomach has a contrast medium, most of the contrast medium, then it means there is some pyloric obstruction or there is some emptying of the stomach. There is a problem with the restrictive or obstructive diseases there. So I told you 15 minutes. The contrast should, if contrast remain in the stomach even at 4 hours, it means there is some pyloric obstruction is there. So you can see if you see in the right side upper image. So this image that indicate restrictive. that indicate the restrictive disease, and this indicate obstructive disease. This is a stomach VD view of the stomach. If you see the wall, the red arrow on the upper one, red and black arrow, that indicate the wall thickening. Pyloric stenosis or eosinophilic gastropathy or hypertrophic gastropathy. So this is a disease of the middle age and old age dogs which are on the food which are chronically allergic to them, and that can lead to eosinophilic gastropathy or hypertrophic gastropathy, and that will restrict the movement of the contrast medium as well as the food from the pylorus. If you look, concentrate on this portion, so you can see there is restriction is there, restrictive thickening of the pyloric valve which prevent the dilatation of the pyloric sphincter in the chronic hypertrophic gastropathy, pyloric stenosis, inflammatory gastropathy. Means on contrast, there will be 3 lesions. I'll show you. So contrast will move, but that will form a small streak, and those small streak will show up as a beak, string, or tit lesions are there. But here you see there is some space occupying lesion, some neoplasia, or even some foreign body can be there. So that is obstructive lesions. So there will be filling defect will be there. The obstructive lesions will have a filling defect. So neoplasia will not allow the contrast medium to percolate. So that means that will be absence of contrast medium at a particular point. That is the filling defect. So that will show up in a obstructive lesions. So here you see most common are gastric adenocarcinoma in dogs, means obstructive lesions, means especially there is when old dogs, and lymphosarcoma in cats. So here there is a gastric enlargement because of the chronic obstruction that lead to because of the pyloric mass. If you see PA, this is pyloric antrum which has a gas bubble in it, and the white arrow that shows the margin of the stomach. So that has gone beyond the costal arch. I told you whole of the stomach in a normal animal should be within the costal arch, within the rib cage. But now you see it has gone beyond. It means there is some dilatation or some lesion is there in the stomach which has grown up, and the stomach wall has grown beyond the rib cage. Here you see the rib cage and pyloric antrum. Here you see the pylorus. So pylorus, so these are the wall has gone beyond. So this was in a cat with a lymphosarcoma of the stomach. So that stomach has gone beyond the. So when we performed contrast, you can see 2 hours. So you can see that these are the lesions. These are called tit lesions. If you see tit lesions means there is. You can see streaking of the gas. This contrast medium. After 2 hours, the most of the contrast medium remain within the stomach. Even after 5 hours, you can see there is one. Here it is. This is called this one. These are called string tit lesions as well as beak lesion. I'll show you the beak lesion as well. So these are small because of the wall. Means here the walls they are hypertrophied. When the walls are hypertrophied, the lumen will shorten. When lumen will shorten, the contrast medium will form a string, or it will form a tit lesions as well. So this is technically we call it. So after 5 hours even as well. Here you see the beak lesions. It looks like a bird. You can see red arrow as well as the yellow arrow. It looks like a beak of the bird. So this is you can see there is hardly you can see any filling defect. Whole of the stomach is filled with the contrast medium even after 5 hours, and there is some constriction is there. So here the same constriction, there is some string. This is a string lesion. This is a string lesion because of the hypertrophied wall. So this is a string lesion. Strictly showing string lesions on contrast medium. So this is because of the hypertrophy, chronic hypertrophy. So here you see adenocarcinoma in a dog which has a filling defect. If you see the filling defect, so although the stomach has a lot of, but you can see that you can see observe the filling defect in the contrast medium. You can see here in this portion, some part of the stomach doesn't have a contrast medium. Here you see I'm highlighting this portion, this lacking. So here lacking. So this is a typical sign of some stomach neoplasia in the stomach. So here you see allied. This is allied pylorus. So pylorus has gone. So here this is a narrowing of. You can see I'm going to highlight this portion in next slide. So this was a case of adenocarcinoma as well. So you can see there is some. This is a filling defect. Here is a filling defect. There is a filling defect, means the contrast medium is not going, and this is a string as well. Means some part of the contrast is going from the pylorus and entering into the small intestine. So this is restrictive as well as obstructive lesion. So this is a typical of a sign of neoplasia. Neoplasia of the gastric wall as well as gastric mucosa. So here is obstructive lesion because of the, you can see the red arrows as well as the blue arrows. This is all mass inside the stomach, So you can see even here, the filling defect is visible. The stomach contrast medium never ignores such lines, these signs. These can indicate that there's some growth is there, which doesn't allow the contrast to percolate. Okay. So now comes to the radiography. That was the stomach. So radiography of the small intestine. So if you look into the small intestine, so the small intestine is this. Here is the stomach, which I already discussed. This is the stomach. So from stomach, the duodenum will start. This is the duodenum. So if you see the duodenum, here is the duodenum. From here, the duodenum, the large, that blue line is the large intestine. You can see underneath here everything. This is a small. These are the small intestine. In lateral view, the duodenum will be visible just in the middle of the abdomen, and the duodenum is the portion of the small intestine which is not mobile as compared to the jejunum, as compared to the ileum. They are more mobile, but duodenum is not as mobile because it is connected with the ileum as well. It is connected with the colon as well. It is connected with the stomach. It is connected with the liver through the ligaments. The different ligaments are there. So if you see, look into the VD view, the stomach is there, and if you look into this portion, especially I'm going to highlight this portion. This is duodenum. This is duodenum right side. If you see, this is the duodenum. So it will make a curve as well. So this is a duodenum. So duodenum that will run parallel to the right abdominal wall. So it's a fixed. But other part of the small intestine, they are not fixed. So jejunum, ileum can move anywhere. But duodenum remain fixed because it has a connection with the stomach. It is a connection with the liver. It has a connection with the colon through its different ligaments. So that's why duodenum is fixed in nature. Even X-ray, it is clearly visible if near the right side of the abdominal wall. So this is here is the cecum, and the blue question mark like this is the large intestine. These are the large intestine. I'll be discussing later on as well. The rest part. So jejunum and ileum, they are relatively mobile except at its terminal. So that's why it changes its position in X-rays. But duodenum and the large intestine. The large intestine means ascending colon, transverse colon, as well as descending colon. They remain in a fixed position. So anatomically demarcation of a small intestine, anatomical demarcation of small intestine in contrast medium. So if you look into the stomach, if you see the contrast, the stomach is there is having a contrast medium, and this is the VD view. If you see the descending colon, descending duodenum, here is a descending duodenum. So here you see the same, which I already discussed. I highlighted with using the contrast medium. So fundus, body of the stomach, pylorus, duodenum, flexure of the duodenum, and when duodenum that enters into the duodenojejunal flexure, so it will be clearly visible when you go for the contrast radiograph. So after 15 minutes, so that this normal dog, it should be visible like this. Okay, so 15 minutes. So this part of the contrast medium should enter into the small intestines. So here you see after 30 minutes, you can see jejunum should have contrast medium. So this is all should be visible. So serosal detail, although it's visible in the survey, but mucosal detail is more visible when you go for contrast. Already I discussed about this one. Mucosal detail more visible in the contrast medium. Here you after 60 minutes, you can see most of the contrast medium should be in small intestine. So it should be there in the small intestine. So this is, so within 5 hours, barium should cross GIT, and 3 hours in cats. So you can see this is a point which I want to discuss, especially in cats. In cats, this is called string of pearls. If you see the duodenum, this is called string of pearls. It's not an abnormality. In X-ray, if you perform a contrast radiography in a cat, if you look like this one, never ever confuse it with a linear foreign body. This is not a linear foreign body. This is string of pearl, which is characteristics of the cat. So linear foreign body, I'll show you the X-rays of the linear foreign body as well. But this is a normal character of the feline upper GIT. So disease of small intestine. So most important is ileus. Ileus means the failure of the passage of intestinal content. When intestinal content are not able to pass small intestine in normal fashion. So then it is called ileus. It can be because of 3 reasons. Mechanical ileus, when there is some mechanical physical obstruction is there. Maybe because of foreign body, maybe because of some neoplasia, maybe because of some space occupying lesion inside like lymphadenopathy, which is pressing the small intestine, doesn't allow the passage. And the second is the functional ileus, which is called paralytic ileus, means when the intestine are not able to contract properly. These peristaltic movements are absent because of the neuromuscular problems or some vascular problems. So this is called functional ileus or paralytic ileus. So this is paralytic ileus has a very grave prognosis. So I'll show you the X-rays of all these. Even some peritonitis, traumatic peritonitis, or some pancreatitis, that can also lead to ileus. So that peritonitis is called inflammatory ileus. So distinction is very important because the treatment is different as well. The prognosis that also depends upon whether it's a mechanical ileus, paralytic ileus, or inflammatory ileus. So the prognosis for mechanical ileus is very good, grave in case of functional, and for inflammatory, the animals, they are having good, poor to, I think, fair prognosis is there in inflammatory. So grave prognosis is there in the paralytic or functional ileus. So radiographic features. So let me discuss about because intestines, small intestines are quite long. It starts from the stomach, it goes up to the large intestine. It's a big, huge, hollow organ. So obstruction can happen anywhere. So it will. So radiographic feature that will vary as per the site of obstruction, whether the site of obstruction in the initial part of the intestine, middle part of the intestine, or the caudal part of the intestine. Means if the proximal duodenal obstruction is there, so then may not be intestinal dilatation, may not be visible. But if there is a proximal jejunal obstruction is there, then the few dilated intestinal loops will be visible. Then if it is distal jejunal obstruction is there, then many dilated intestinal loops will be visible. It means depending upon where the obstruction, number of dilatation of loop will vary. So an acute obstruction result in dilated, distended, gas-filled loops, which will later on will become a fluid filled with the time. So initially it will be gas filled in X-rays, and if you take an X-ray after 2-3 hours, the fluid will start entering into that part, so it will be fluid filled as well. So gravel sign, this is indicate some chronic partial obstruction of the intestine. So let's start with the radiographic signs. This is the important part. These are the parameters which you have to keep in mind while I should say diagnosing whether ileus is present or not. When you see a particular loop of the intestine, which is diameter is more than 4 times the diameter of the last rib, or 2 times the height of lumbar 5th vertebrae, then it means there is pathological dilatation. If it is less than that, then it's not a pathological dilatation of any particular. I'll show you the X-rays as well. In cats, a more than 12 mm diameter, that is pathological. So severity of the lumen distension that directly proportional to the completeness, how much obstruction is there, whether it's a partial, then less dilatation. If it's a complete obstruction, more dilatation will be there. Another important point, this one, fourth point, no loop of small intestine should be more than twice the diameter of any other loop. In the same animal, in same X-ray, if one loop is double the diameter of the another loop, it means that is a pathological. Proximal obstruction lead to focal dilatation. Obstructed dilated leaving a gas field initially, I already discussed. There is another term which we will be using really. This is called sentinel loop. Sentinel loop, sorry. Sentinel loop, this is a localized, when there is a localized obstruction is there, means especially when there is a strangulating hernia is there or small obstruction, partial obstruction is there. So that leads to localized, that is called sentinel loop. So generalized uniform dilatation, that indicates functional. So when I'll show you the X-ray, then you will come to know about these points. But these points should be there. These are the practical points whenever you look for any X-ray for ileus. So normally mechanical ileus means some obstruction is there, physical obstruction is there. That physical obstruction is most commonly is because of foreign body. It can be because of intussusception or some parasites or neoplasia. So obstruction can be partial or so this all depends upon. So that's why let me show you those X-rays. This was an X-ray in which this is an X-ray in a dog in which the obstruction was because of the mango kernel, mango kernel, mango seed. So that led to, you can see the loop. This is called sentinel loop, localized obstruction. This is sentinel loop. Okay, so you can see it's a 3.05 centimeter, and here you see L5. This is L5. L5 height is 1.11 centimeter. You can see almost 3 times. This loop is 3 times than the height. It should not be more than 2 times. This should not be more than 2 centimeter. Should not be more than 2 centimeter. It means this is a sign of mechanical ileus. And here you see the rib. Rib is 0.61 centimeter. So more than 4 means when you multiply by 4, it comes out to be 2.4. So here it is 3 centimeter. It means this is a sign of mechanical ileus. This is how you can estimate the mechanical obstruction. Here this is the same dog. So when operated, this was the mango kernel which came out, mango kernel. So this was the mango kernel which was obstructing. You can clearly see that obstruction is there. So here to the mechanical ileus is there. This is sentinel loop, here the dilated. If you see the dilated loops, this was more than twice 5th height. Here you see the height, here you see the height. Number 5th, you can see twice there as well. So same way, this was the case in which there was a bunch of cloth, a small cloth was there. So you can see here this cloth was obstructing. You see the L5, here you see more than double these are. So this was more distal. You can see here you see this one. This is only single loop. It means the cranial part of, means the duodenum. Obstruction was in duodenum, or like there was a duodenojejunal, near the jejunum, the obstruction was there. But here you see more loops are dilated. It means there is a caudal obstruction is there. Caudal obstruction is there. Yeah, either it's a distal part of the ileum or near the ileum, or the distal part of the jejunum is involved. So you can see this part was obstructing. Means from looking into the X-rays, looking into the number of intestinal these loops are dilated, so you can judge whether it's a distal or the cranial obstruction is there. So let me show you. This is a corn cob. If you see the corn cob obstruction, so that led to the. So this is a strangulating hernia. You can see this is strangulating hernia. Only one loop is dilated. It means cranial part of the intestine is dilated. Cranial part of the jejunum is dilated. Here you see this was operated for, and that led to the obstruction as well. So here you see the, and this was. So this was a very interesting case which we recently operated. It was a ileocecal. Ileocecal stricture was there. So ileocecal stricture was there, but that allowed the passage of food material to little extent. There was not a complete obstruction, but that led to, this is a centennial loop. This is called centennial loop dilatation. Observe this is also known as hairpin-like centennial loop that indicate the mechanical obstruction. So same dog, this dog when operated, after operation, next day when surgery, X-ray was done, you can see that mechanical obstruction, that sign of a radiographic sign of mechanical obstruction was not visible because the passage has become patent. The gas was able to move. So here you see the ileus because of some radiopaque material. So now comes to the second. This is a functional ileus which doesn't have a proper gray prognosis is there. So this is paralytic, adynamic, absence of paralysis. This is all because of neurological origin or muscular dysfunction of intestine. So intestine are not able to contract. Peristaltic movements are absent. So there will be a uniform dilatation, generalized distribution. So there will be same way if you see uniform dilatation of all the loops. So this was the case. So when we operated, it was uniform. So such type of cases in which there is a uniform dilatation of the small intestine present in the abdomen, this is called complicated functional ileus and has a gray prognosis. Very grave. And this case was when we took a biopsy, this case was lymphosarcoma of small intestine. So that led to the this functional ileus. So now comes to a traumatic and inflammatory failure of the passage due to the focal neurological or muscular dysfunction. So this is radiographically, there was radiography. You can say, I'll show you the X-rays as well. So these are the all characteristics which will be visible in X-rays. So peritoneum, there will be the serosal detail will be absent. So I'll show you. So serosal detail, if you see, look at this portion. If you look into this portion, these are small intestine. The loop serosal details are not visible. You can, it looks like a ground glass-like appearance. And these are not, these are typical sign of peritonitis. And this peritonitis led to a traumatic, or I should say infectious or inflammatory ileus. So here you see there is a ground glass observed just caudal to the stomach, and this was a case because of peritonitis, and peritonitis led to the pancreatitis led to the peritonitis, and which led to the ileus formation. So this is a focal peritonitis which led to ileus. Although dilatation is not there, but serosal detail is not visible as well. So obstruction is because of the peritonitis. Here, this is which I told you about the chronic obstruction. So this is chronic obstruction which is available as a gravel. If you see the double arrow here, looks like a gravel is there, sand is there. So this one is typical sign of chronic obstruction. Here to the gravel sign in a chronic obstruction, lot of looks like a sand or gravel is there. So this is a whenever it's visible, it looks like it is a diagnostic point for chronic obstruction. Now comes to the linear foreign body. So whenever the linear foreign body is there, so very commonly found in our patient, especially the cats, they have a habit of eating these linear foreign bodies. So common in cats, typical, it will be accordion like bowel, or plication will be there. Plication, how it looks, I'll show you those ones. Don't confuse the string of pearls. I already showed you that duodenum can show up as a plication, but that is a string of pearls. That is a normal in cats. Okay, so remember to check the cat under the tongue for string. So this is commonly seen. So here another place as well. So whenever the cat has a this linear foreign body, we always check the tongue underneath the tongue. Most of the cats, they can have a string entangled under the tongue as well. So you can see most of here, this is called accordion. This is called accordion, this one. These are called accordion like bowel, plication. These are gathered loop of bowel which are gathered around the linear foreign bodies. Linear foreign body. This is called accordions. Accordion like that. So here when you perform the ultrasonography, the string will be visible like this. Here, this is the same cat. This is the cat which we operated. Same cat has a linear foreign body accordion. You can see this, these accordion, this will look like a, here it is. This is a string. You can see the string. So most of the time, or like I say, 100% of the cases, this string, linear foreign body, will stuck in the mesenteric part of the intestine. So this is called accordion or plicating. This is a plication. This is called plication, and it will be visible like this. Same way in the dog, you can see the plication. Here you can see the plication. You can see most of the intestine will be limited in the ventral part, and it will show like a plication. Plication is there. Here you see, when I'll be highlighting this portion, you can see the plication. Here you see the plication in the ventral medial. So note the plication and appearance of the gas distension. You can see. So this is a radiopaque, another foreign body. This is another for the semi-radiopaque. I just want to show you these ones bigger than that. This is just a duplication of the slide. So another thing which I want to highlight, sometimes the parvovirus enteritis. Parvovirus enteritis in puppies can also show up as a enlarged small animal, small intestine dilatation because of that. But this is not because of obstruction, whereas these are because of infection. So you have to rule out the parvovirus infection. If there is enteritis, is there? Actually, this can be, but not because of ileus, it is because of infection. Now comes to another important disease, intussusception of the small intestine. Intussusception is when there is a telescoping is there, invagination of part of the segment of the intestine in other part of the adjacent part. This is parvovirus or any diarrhea, chronic diarrhea can lead to intussusception. So there is two portions are there, intussuscipian. Intussuscipian is the part into which intussusceptum will enter. This is the intussusceptum which has gone into intussuscipian. Intussuscipian is the recipient part. Intussusceptum is the part which has gone into the intussuscipian. So these are two parts are there. Complete obstruction or incomplete obstruction can be there. So ileococolic junction is the most common part of obstruction or intussusception. Survey radiography will show the mechanical ileus. Sometimes you can see, but contrast radiography will be more diagnostic as a coil spring like. So let me show you here. This is survey radiograph. If you see this one yellow, just follow the yellow one. This is intussuscipian recipient part, and here is the intussusceptum. Let me again highlighting this one, and this is intussusceptum. This is intussusceptum that has gone into the intussuscipian, and when you look into when you perform the contrast radiography, then here is the coil ring. It looks like a spring, so big spring. This is called coil spring lesion, which is a typical diagnostic or radiographic diagnostic sign in case of intussusception. So let's come to the last part of my presentation, radiography of large intestine. So in a normal dog, C-shaped, usually gas containing. So it's a distensible organ. And considerable size, considerable increase in size is there if the diameter is greater than 1.5 times the length of L5. Means L7, sorry. L5 is for small intestine, that is a height. But here 1.5 times length of L7. So enlargement can be localized or it can be generalized. So readily displaced by because I told you in the beginning that large intestine is basically, it's a fixed structure. So that's why any enlargement of the adjacent structure can lead to its displacement. So two most common cause of terminal colon or rectal displacement is sublumbar. Sublumbar means below lumbar vertebra. If there is lumbar lymph node enlargement is there, or any enlargement of soft tissue enlargement is there, that can push the descending colon downward, but prostate enlargement will push it dorsally as well. So sublumbar lymph node enlargement can cause ventral displacement. Prostate enlargement will cause dorsal displacement. So here you see A part. This is prostate, uterus, or urinary bladder. It can push it dorsally, and the lower picture, if you see, so this is a sublumbar, it will push downward. So let me show you this one. This is a sublumbar. Here you see this one is a sublumbar growth, and here is the descending colon. You can see it is pushing it downward. It means there is a narrowing of the lumen of the descending colon. Descending colon. This is because of the sublumbar. So here too there is a, you can see the course. So it is that descending colon is being pushed downward because of the sublumbar growth. So these are sublumbar lymph nodes. Especially in such cases, I will highly recommend go for per-rectal examination and try to see any soft tissue density just below the lumbar vertebra, just cranial to the pelvic inlet as well. And you can easily diagnose such animals which are having sublumbar. And this is a diagnostic point that there is some lesion is there in the sublumbar region which has pushed the descending colon ventrally. And here is the prostate, so which has pushed the descending colon dorsally and led to the narrowing down of the lumen of the descending colon. Such type of dogs, they have a tenesmus. They have they try to defecate, and they keep on sitting in the defecation posture for a longer time. And such type of dogs, they are prone to perineal hernia as well. So these so here you see, if you see the cecum is there on the right side, and the descending colon, or here it is the ascending colon, transverse colon, and descending colon is there. This is a normally it should. So transverse colon normally is in contact with the stomach, liver, and pancreas, and descending colon is in contact with the spleen. If there is any splenomegaly or liver enlargement or stomach enlargement or pancreas enlargement, so then the transverse colon will be pushed away from its normal position, and the mesenteric lymph nodes will be at this point in between. So it will also alter its position when there is any mesenteric lymph node enlargement is there. And urinary bladder and sublumbar lymph node will be present at this point. Prostate and uterus will be at this distal part. Descending and vagina will be at this one. Any alteration of these organs will alter the position of the large colon as well. So contrast radiography, you can go for contrast radiography, which is called barium enema. Rather than going for a barium swallow, we can go for barium enema as well. For procedure is food is withheld for 12 hours. Cleansing enema can be there, and barium can be injected intrarectally at the dose of 10 ml per kg. And this is the conditions. These are the indications in which there is intussusception you want to misdiagnose, or there is some mechanical obstruction of the large colon is there, or some mass lesion is there in the cecum, or even there is restrictive lesions, inflammatory bowel disease, which has led to the thickening of the wall of the descending colon, and that has led to the restrictive lesion. Then the barium enema can be diagnostic to look into the thickening of the wall of large intestine as well. So here is the barium enema, which was used to diagnose the intussusception at the level of ileocecocolic junction. If you see the ileocecocolic junction, so here up to here, after this there is obstruction in the contrast medium. So this is all intussusceptum. So this is all intussusceptum or intussusceptum. So this is all even intussusception can be diagnosed using the barium enema as well. This is another barium enema was done to diagnose ileocecal stricture. So here is the stricture. So you can see observe the dilatation of the small intestine as well. The small intestine will be dilated. So even rather than giving barium swallow, barium enema can be done to look into the site of stricture as well. So megacolon can be there as well. So megacolon, how we can diagnose is when the length of, so length I'm talking about L7, this is L7. So this is the length I'm talking about. So here is the height. This is the height of L5. So this is the length of, so I'm talking about when you compare with the large intestine, then compare with the length of L7. When you compare with the small intestine, then compare with the height of L5. Okay, so let's come to the last conclusions. Conclusion is filling defect in contrast of a hollow organ that indicates space occupying lesion. Then course of trachea can help you distinguish between DH and PPDH. Right lateral abdominal view is diagnostic for GDV. Pathological dilatation of small intestine is when 4 times at the width of last rib and 2 times the height of lumbar second vertebra. In cat, when it is more than 12 millimeter in diameter, no loop of small intestine is more than twice the diameter of another loop. String of balls is normal. Never confuse it with the linear foreign body. Centennial loop that suggests localized obstruction in radiograph in a normal colon, usually less than normal colon should be less than 1.5 time length of L7. So that's all from my side. So if you have any query, so please let me know. Thank you very much, sir.
Thank you very much, sir. Please check if you can access the chat box, sir. There are some
Chat
queries.
box. Yes. Chat box. What is dilution rate of gastrography? In gastro meaning you can take 1 ml and dilute in into 50%, means it taking 1 ml of water as well. Means half 1 ml that 1 ml water, and you can inject, you can give by mouth as well. So it will work efficiently, especially whenever there is a rupture, perforation of intestine. Can we get the PDF? PDF. I'll think
Sir,
about that.
we will share the video that will serve the purpose, I believe.
Pardon?
We will already share the video, so that may help. That will serve the purpose. But
yes.
I think people want the X-rays like
PDF. I think it will be shared in YouTube by your Oriheal. I think that should be sufficient. You can repeatedly look into that video, and yeah, then you can refer those videos as well. Explain the differentiation of the contrast radiography of hiatal hernia and esophageal mass showing X-rays. Yeah, esophageal masses will have filling defect. But hiatal hernia will not have a filling defect. You can clearly see the cardia, and there is a gastroesophageal structure, gastroesophageal center. So filling defect will be absent. That will be the. What is the view for GDV? Already discussed. Right lateral view for the and inguinal hernia. How we can see inguinal hernia? Yeah, inguinal hernia. You can see most of the time inguinal hernia is there, especially if they. I have a personal experience in a female dog. Most of the time when inguinal hernia is there, then genitalia is the organ which has herniated. Genitalia, uterus and ovaries in intact female dogs. But if it's a male, then most of the time it's a small intestine. Then X-ray can help you to differentiate as well. And what you can do is, if you want to differentiate between whether it's a small intestine or it's a genitalia in female dog, then you can go for contrast radiography. Give a barium swallow and keep on taking a serial radiography after every 15 to 30 minutes. Then if the contrast medium go into the hernial sac, then it means the hernial content has intestinal contents, not genitalia. Detailed, deep presentation. Okay, thank you very much. I'll take it as a compliment. Please share PPT if possible. Thank you very much for valuable. Thank you. Yeah, so much. So I highly appreciate your positive response. How to evaluate rhinomegaly? So this will come in next. This will come in next webinar, which I'll be dealing with all in abdominal organs. I'll be dealing with the liver, kidneys, adrenals, prostate, urinary bladder, then even uterus. All these will be covered in next webinar. Okay. In case of perforation, iodine dose I already told you, 1 ml, dilute it with 1 ml of the water and give 1 ml per kg. Inclusion site mention height of L2 for comparing small intestine. Oh, sorry. If I said L2, no, it's L5. Sorry, if I did to L2, then it's my mistake. It should be L5. Sir, you said positive ciliography for DH, but if we use one endothorax through diaphragm, ciliography, I told you, you are not going to use barium sulfate. You will be using gastrographin or ditrizoate, or even urographine can be used, which will not have any complication. Which book? Okay, probably my YouTube video will be the best for further reading, or you can go for Basawa manual of radiography and radiology. That will be good. Basawa manual.
I will be sharing soon, sir. That I will share.
Yeah, people, they are knowledge hungry. I can see the hunger.
Sir, 150, more than 150 veterinarians were till the end of the webinar, and it was a 2.5 hour webinar, continuous webinar. So you can understand, more than 300 veterinarians attended this webinar today.
Yeah, thank you. Thank you for insight. You are king. Okay, thank you, sir. I'm king without a crown. Okay, I take it as a compliment. Ronjan sign in case of enterolith. Yes. Enterolith are not so common in dogs, I should say. It's more common in horses. Enterolith. But if it is, if there is a history of eating of the soil or eating of the sand in dogs, it can lead to enterolith. But if it is there in enterolith, and the enterolith will look like a radio opaque. It will look like a stone inside. So it will be you can easily diagnose by looking into the X-ray if there is enterolith. How to manage? That is a surgery part that can be lengthy. So once I'll finish this radiology, then if I come to the surgery part, then I'll show you the videos for those ones as well. So great lecture. Okay, thank you very much, sir. Medical management of hairball. Medical management of hairball. There is bromthaline is there. You can give pineapple juice. Yes, fresh pineapple juice. So which has a bromthaline. So this bromthaline can digest the hairs. Otherwise, there is no gastric acid can't digest hairballs. One thing, they are very stubborn. Even gastric acid can't digest it. Only the pineapple juice has a property to digest the hairballs. You can give this fresh pineapple juice continuously for 1 week, then slowly it will start disintegrating. For post contrast, 15, 30, 62 hours is starting a feeding of contrast, or only one time feeding has to be done for the contrast, not repeatedly. No. One time contrast has to be. Okay, sir, this is all from my side. I think these are the questions in the chat box.
Sir. Yes, sir. Yes, sir. Yeah. So on behalf of all the participating veterinarians and the entire team of Oriheal Lifesciences, sir, we extend our deepest gratitude to you for your today's session. Your session was truly exceptional, highly informative, and intensely practical. The way you simplified the complex technique of barium meal X-ray was simply great. So we understood so many key aspects of a small animal radiology for today. Your explanation were not only crystal clear, but also immediately relevant to their daily clinical practice. We deeply value your expertise and generous support in advancing veterinary education. Thank you for contributing your invaluable knowledge to this initiative powered by Oriheal GI Medicines. We are enthusiastically looking forward to the next sessions. Thank you so much.
Thank you, sir. And people are demanding for the webinar video on YouTube.
Sir, they are already there. All the past webinars are already there.
Yeah, past webinars are there. Yes.
Within this week, this will also be uploaded.
Oh, okay. See you next time. So I'll be preparing for other abdominal organs. It might, because there is a festival season is going on. So we have to see about those festivals. People might not be busy. I want that maximum number of people should attend the webinar. Yes. Okay. Thank you, sir. Thank you, sir. Thank you.
Have a wonderful Sunday evening, sir.
You too. Okay, bye.
Okay, sir.
Most trusted pharmaceutical company for companion animals of the year goes to Oriheal Lifesciences Pvt Limited, Dr. Vishal Sharma from Oriheal Lifesciences Pvt Limited.